I want to thank the panelists here. I'm going to disappear and let you guys do your thing. Dr. Gamares, you're on. Looks like we're good. Okay, I'm out of here.
Thank you, Bob. And very welcome, Dr. Palmier and Dr. Kumaris. Excellent, excellent talks. It's always so refreshing. And I always feel envious as a medical oncologist. I don't have those cool pictures to show. And it's so gratifying when you kind of can clean up those tumors and then those fantastic. And despite being a medical oncologist, because I was trained by a lot of surgeons, Dr. Woltring, Wang, Boudreau, during my residency, I have a lot of soft corner for surgery and surgical intervention. So I have definitely seen a lot of benefit with surgical site reduction. And this is one of those cancers where there is definitely a role for surgery, even in metastatic setting, like as you mentioned. And Dr. Gumares, what a lovely presentation, describing different forms of embolizations and your protocols. We have a big list of questions in front of us. I would like to kind of bounce these questions around. Let's see if we can tackle at least 60 or 70% of those. All right, let's start with Dr. Palmier first. So can you re-resect a liver tumors when previous liver surgery left a lot of scarring and adhesions? How's your experience with the re-resections?
The answer is yes, you can resect again. In that series, a third of my patients with carcinoids had more than one liver resection. They tend to be the younger patients who do it because as patients get older, you can actually get to the finish line with a normal lifespan with carrying on with medical therapies. And as I showed, the younger patients tend to get more tumors sooner. I've had quite a few patients have 3 and an occasional patient have 4. But each time it gets more difficult to dissect the liver out a second and a third time. And I can pretty much tell one of the times when I'm closing that this is going to be the last time I'm going to be able to work on this liver.
Perfect.
The PNETs, not so much. It's about a quarter of the patients instead of a third have had more than one liver resection.
Gotcha. Thank you so much. Dr. Gumares, how's your experience with post-embolization carcinoid crises? How much of it is this a problem, and what do you guys do to kind of minimize the risk? What are your protocols? And I'd also extend this question to Dr. Palmier afterwards regarding post-surgical or intraoperative carcinoid crises management. I think you're on mute.
It's easier if the microphone is on, isn't it? Aman, it's great to see you again. I think you and I were part of this these lectures here a couple of years ago. So it's good to see you again. Dr. Palmier was a great lecture. Thank you for showing your experience. I'd like to just share our experience. We don't see carcinoid syndrome post-embolization because 100% of our patients are using octreotide up front, and we don't stop that for our procedure. So we don't see that basically happening. We do see a little bit of post-embolization syndrome, very mild pain and maybe some discomfort in the abdomen and fever as a post-embolization syndrome effect. But for the most part, our patients tolerate the procedures very well. Aman, I can't hear you.
Oh, sorry about that. It does work better with the mute off. Dr. Palmier, how about, I know this is a personal research interest, an area of research interest for you as well. And can you throw some light about on carcinoid crises and perioperative management?
Yes. So carcinoid crisis is a sudden onset of hemodynamic instability with no other plausible explanation, such as being behind on blood or intravenous fluids or compressing organs in the abdomen. Our experience is that it occurs in about 25% of operations, and the factors that predict it are having neuroendocrine or liver metastases is a strong predictor of it. We don't see it very often in patients who do not have liver metastases. It's definitely more frequent in patients with small bowel primaries, more frequent in patients who have carcinoid syndrome, and the other factors that have correlated have been older age and longer anesthesia times. That said, any patient with any kind of tumor can have one. The old story was that if you are on octreotide, LAR, you aren't going to have it. We've proved that incorrect, and so has the group from San Francisco and other centers. We've just gone down the line. We've tried giving people a pre-op dose before they go in the operating room. It doesn't stop it. We've given people intraoperative doses in the middle of the operation. It doesn't stop it. And I finally did a study where we ran hundreds of patients on continuous intravenous infusions at a massive dose of 500 micrograms per hour, and it had no impact on carcinoid crisis rate. The old belief was that carcinoid crisis was a sudden massive release of hormones from the tumor that overwhelmed the patient, and therefore that was the whole basis of using octreotide. So I finally did an invasive study in which we had catheters in the heart, we were doing echocardiography, and we were measuring hormone levels throughout the operation. And what we found was that patients who had crises had higher serum serotonin levels, an average of about 1,000 units, compared to only 435 for patients who did not have a crisis. But contrary to the old belief, there was no massive release of hormones during the crisis at all. In fact, levels during crisis were somewhat lower. And so I'm just now putting the finishing touches over here on this computer on my next paper, which is 195 consecutive operations with no octreotide at all. The rate of carcinoid crisis did not increase. Their duration is actually shorter, and there is no increase in the postoperative complications. So we're abandoning octreotide use altogether.
Wow, great.
So, Aman, let me just ask something to Dr. Pormier. Why do you think that in the surgery you see with a certain amount of patients, significant amount of patients, you don't see at all with a minimally invasive therapy like ablation or blend embolization or Y90? Why do you think that's the cause?
I think we have more things going on. I mean, we have to come up with a new model for what is actually the basis for carcinoid crisis. And so now with my data, my new model is that having high serotonin levels somehow makes your whole vascular system just more susceptible to perturbations from some types of interventions. So, for example, in my operations, we've got patients who are under general anesthetic and they're getting all kinds of drugs, and I'm messing around in the abdomen. So there's a lot more going on that could result in a perturbation compared to a single event like yours, which is an embolization.
Right. And basically, I think it's important to clarify to patients that surgery is very important. There's no doubt about that, but there is a quote unquote trauma under control during the surgery, and we basically offer a procedure to kill the cancer cells with a 2 millimeter nick through the patient's wrist. So that's definitely part. I agree with you. That's part of the explanation to see the difference in the incidence. Carcinoid syndrome. Thank you.
Perfect. Sounds good. That's excellent. Let's move forward. Dr. Palmier and Dr. Gomez, this will be a common question, both of you. For a liver-only disease, we don't have extrahepatic disease, where do you put liver transplantation in the picture, especially with nice local regional therapy options or surgical cytoreduction options? I'd like to hear your thoughts on liver transplant.
Dr. Ramirez, do you wish to go first?
No, you are the surgeon in the group here. You go first. I have my position pretty clear on that, but I'll give you, as you are more senior, I'll give you the right to go first.
Okay, but then I'm going to reserve the right to ask you a particular question about it. I don't see much role for liver transplantation. I reviewed the world literature on it, and I mean, I think the whole idea of what someone would get with a liver transplant is you take out a diseased liver and there's no disease anywhere else, and you put in a new liver that has no disease, and you hit the home run. Well, the data show, back to the whole issue of recurrence, the 5-year recurrence rate is about 93%. And it tends to be miliary recurrence, which is not just these solid, large tumors that I can go enucleate, but they're just millions of little tumor growths all throughout the liver that I can't operate on. It would have to be something that would be embolized by someone like Dr. Guimaraes. Once you have a transplant, you're painted into a corner with a lot of the issues that are required to maintain a transplant, such as immunosuppression. And I find that people, while they're willing to give chemotherapy or embolize someone's native liver, they don't seem to want to touch a transplanted one. And I can understand why someone like you, Dr. Chowan, wouldn't want to give chemotherapy to someone who's already immunosuppressed with transplant drugs. But I have not understood why people are unwilling to embolize a transplanted liver. So would you do that, Dr. Guimaraes?
Absolutely.
Yeah, I think you should.
Absolutely. We've done many cases, and again, it's not about us feeling comfortable or not comfortable of doing things, it's about patient care, right? Sometimes we lose the focus that it's not on us, it's on the patient. So we've been using very special techniques. That's why I was showing the picture with a small vessel that is feeding the tumor. So we could, there's one technique that I did not mention here, but it's very important for the patients to know, is what we call segmentectomy. Segmentectomy is similar to dropping an atomic bomb, equivalent to an atomic bomb, in a very small portion of the liver, and that portion of the liver is going to be totally destroyed. There's no tumor left, or neither liver left in that short segment. So I don't know how much, Aman, you are familiar with the segmentectomy concept, but this for lesions that are, let's say, segment 2, 3, that you can really compartmentalize. You can have a very simple 1 or 2 vessels feeding that corner of the liver, and the patient has a large liver preserve and good liver function. Today, we can inject 500, 600 gray in a single vessel. There's no tissue left. And that's 2 procedures. I mean, this is a prep workup, like I described, the day of the treatment. Both procedures done as an outpatient. Both procedures done through the patient's wrist. I mean, it's hard to imagine, and I agree with Dr. Pommier 100%, that it's hard to imagine to submit a patient for a transplant if we have a lot of surgical and minimally invasive options today. There are centers in the world, though, that are performing transplant patients with NET. It is very rare. It's very patient-tailored, discussed about that patient in particular. But to me, the best algorithm would be to try to resect the primary tumor, and then with minimally invasive therapy, either Lutathera or us, or sometimes with surgery, resect the liver if it's the only metastatic disease related to the liver. And one thing is important to mention, transplant, even though I believe transplant is very good for liver cancer, for hepatocellular carcinoma, for example, it is not an easy post-procedure, post-transplant life, because the patient needs to take a lot of medications. There's a lot of follow-up. The incidence of complications, depending where the transplant is performed, can be quite high. Not to mention what Dr. Pommier mentioned very well, the immune suppression. I see patients that probably were a little pushed to transplantation in other institutions. They shouldn't be transplanted. They come to us with immune suppression. What happens? We have recurrence of HCC in the liver again. Total waste of time. So I don't think transplant is a good option. I agree.
I think I echo both of your sentiments, and at our institution, I can say that we certainly, as of now, we don't have data to support transplant. All right, so moving on, Dr. Pommier, can you kind of walk us through how does the natural history of disease progression looks like for NETs, midgut NETs, early stage NETs? What are the relapse rates, recurrence, And to follow up question, if somebody goes 10 years out after surgical resection and no relapse, can you consider this as patient's cured? Would it ever relapse again? And can this patient have a secondary primary?
Sure. So, as I said, about 60 to 80% of patients present with liver metastases. When you get into the small bowel neuroendocrine tumors, it's about 20% of patients that don't have liver metastases. Mm-hmm. So I divide those into flavors. I have chocolate, vanilla, strawberry. And the chocolate neuroendocrine tumor is somebody who has a primary tumor and a mesenteric mass. So we just published a paper last week that looked at the issue of these large mesenteric masses at the root of the mesentery. A couple of years ago, we made that a new stage of N2 disease. Before, we just carried whether lymph nodes were positive or negative. And it turned out that wasn't predictive. You couldn't tell how people were going to do based on whether they had positive or negative lymph nodes. And that's because neuroendocrine tumors are different. It's like with breast cancer and colon cancer, people who have negative nodes do well. People who have one node do a little worse. People with 2 and 3, and people who have 10 and 15 nodes do very poorly. Well, what do you do with a neuroendocrine tumor? What's worse? 5 positive little jelly belly sized nodes, or 1 lymph node at the root of the mesentery the size of a Texas grapefruit? I mean, no one knew. So we decided to split it into people who had the big mesenteric lymph node versus not. And what we found was that itself was not predictive, but patients who have the mesenteric mass and don't have liver metastases are way more likely to get them in the future. So they definitely need more careful surveillance. It's definitely a predictor of more aggressive liver disease. And we can also show that they are the ones that are more likely to need a second liver operation besides the age group I talked about earlier. I don't think patients are ever out of the woods with this disease. It is, it's just it's the other side of the, the coin about having a slow growing cancer. It's like, who knows how long it takes to come back. And I recently operated on the liver of a man who had an appendiceal carcinoid at age 8. And he came in, he'd had a right colectomy when he was 8. And he came in with liver metastases. And I thought, this has to be a second primary tumor. I mean, I can't believe that 46 years later, he got liver metastases from that appendiceal tumor when he was treated with a right hemicolectomy. And I explored him, and I did a bronchoscopy on the operating table. There was no other primary. So I think that, yes, he still got liver mets 46 years later. That's my explanation. Second primary tumors are uncommon. Missed primary tumor is much more common, I think. My first rule when I operate on someone is trust no one. I get lots of patients referred to me who were accidentally discovered because of a bowel obstruction or exploration for another person having a neuroendocrine tumor, and they said they took it all out and there were no liver metastases and no spread in the abdominal cavity. And I go back and operate on them, and I find out about 20% of those patients have another tumor in the bowel that they didn't find unless you ran the bowel millimeter by millimeter, feeling it and shining lights through it. And 15% of them have liver tumors that the other surgeon didn't see.
Now, thank you so much. And I would like to mention it to the audience here, and that's the key difference between just a general surgeon and a surgeon which has experience with neuroendocrine tumor nuances. And this is the common theme that you'd be hearing, that the NET specialist or surgeon would look for residual disease. They'll sometimes palpate the whole bowel and all those things. So it's really, I can't emphasize the importance of seeing a NET specialist, especially if you're going for a surgery. It can't hurt to get an opinion from a surgeon in your area with this NET expertise. Dr. Guimarães, a question for you. Somebody has had a surgical resection for a seemingly early stage cancer, but now unfortunately relapsed. Looks like relapse only in the liver mets. Would you go for a local regional therapy or a systemic therapy as your first line of defense for now metastatic disease?
If the patient has only disease in the liver, I would definitely go I would recommend liver-directed therapy. Of course, we need to see what case it is in order to define what technique we will use. Our algorithm, generally speaking, is if the patient has 1 or 2 lesions that are peripheral, we usually ablation, simple procedure, outpatient. If the patient has more central lesions closer to areas that we don't want to treat with ablation because we can damage surrounding tissues, then we tend to use the segmentectomy, as I mentioned to you. We can drop quote unquote, an atomic bomb, extremely high dose radiation, super selective, like a sniper technique, right? Mm-hmm. And then we destroy that amount of tissue in the liver, just a little bit of liver around where the tumor is. And if the patient has multiple mets, and that's the case sometimes, then we can use lobar technique. So inject radiation, not that amount of radiation initially mentioned, but radiation to address one lobe at a time. So yes, I would use local regional therapy as long as the patient has good liver reserve. The patient did not have a major hepatectomy and has at least 30% of the liver in volume preserved. Yes, we'll use local regional therapy without any problem, which does not mean that, depending on the medical oncologist, that we wouldn't use in association with systemic therapy. We definitely can, but I don't think there's data to support either way. Unfortunately, the data in this field is growing. We're having more and more studies, but I don't think there's any data to show that association is better than not. So I would start with liver-directed therapy and go from there.
Perfect. Well, thank you so much. Pamir, for a PNET, which is about 1 centimeter in the body of pancreas, would you enucleate or surveil? What would you do for 1 centimeter?
Okay. Well, we can talk about surveillance as the first issue. It's like if you look at autopsy studies, like a small percentage of patients who die of other natural causes have a small, less than 2 centimeter PNET in their pancreas that never ever bothered them. So that is an idea that these things can be observed. I always ask people, what are you going to observe it for? Because I can't count how many times I have had a patient sent to me with liver metastases that are debulkable from a occult primary, and they've had all kinds of gallium scans and endoscopies looking for a primary. I can't find it. And so I go in to debulk the liver, and what I find is a very small PNET in the head of the pancreas, body or tail of the pancreas, that gave rise to all those liver metastases. So observing it for growth makes no sense to me, because we know that some neuroendocrine tumors in the pancreas have the capability to spread when they're incredibly small, and they never get bigger. They just stay that tiny size almost indefinitely. That said, pancreas surgery is a lot more morbid than bowel surgery. And so if you have an elderly patient, lots of comorbidities, it might be reasonable to observe it and then pick a size threshold. Typically people think 2 centimeters is where we need to think about doing something else. There are studies that have been published on observation. What they show is that the follow-up's short. They're typically only about 39 months, and that's not much in the lifespan of these slow-growing neuroendocrine tumors to say that they don't spread. And the other thing that is shown is that people tend to convert to surgery with time. If you want them scanned every 6 months or 3 months, and all these scans and radiation, all the anxiety and stuff that it provokes, they finally just say, just take the darn thing out and get rid of it for me. And so that has been seen in many of the studies. And the younger the patient is, the more likely they are to do that. So I'll talk about options for elderly patients. We can try observing it. We can treat it with medical therapy. Younger patients, we're more likely to recommend an operation. And the whole idea about enucleating it depends on where it is in the gland. It's like it has to be not close to the pancreatic duct so that I leave a hole in that and it leaks pancreas juice all over the abdomen and causes complications. Can't be close to major vessels. That would cause the morbidity of that kind of an operation compared to a formal resection.
Aman, can I add a comment to Dr. Pamir's response?
Sure, please.
There is a a technique that is called IRE, irreversible electroporation, that has been used in pancreatic cancer in some centers in the world. In US, there are about 6-7 centers that have some experience with this for pancreatic cancer, for primary cancer. But I don't see a reason why not to, even though there's no data to support necessarily if it's effective or not. But in pancreatic cancer, it does have data to support that it's good. To use as an alternative to surgery. So, for example, Dr. Premier mentioned patients with a relatively small lesion around 2 centimeters, 3 centimeters, that is one lesion, especially if it's in the body of the pancreas or in the tail of the pancreas. We in comorbidities, obesity, there's a hypertension, patient with COPD, patient with risk factors for surgery. We definitely should consider, in my point of view, again, take my word with some grain of salt because we don't have evidence, right? Level 1 evidence to prove that. But in our experience, we definitely could use IRE, irreversible electroporation, for those subset of patients.
Perfect. Thank you so much. I always learn something from these sessions. Great. Dr. Guimarães, this question is for you. Can you define the role of multidisciplinary care in the management of NETs? I'm kind of simplifying the question. Question was from a patient regarding how can I get in touch with the decision makers, in the tumor board, and how do physicians, surgeons, interventional radiologists, how do we come and build a consensus, and how should patient decide what's best for them, and can they also talk to the other key team players in that tumor board discussion?
This is a great question. In summary, typically the patient comes to us, to our system, through one of the physicians. Can be directly through me, can be directly through a radiation oncologist, a medical oncologist, or the surgeon. Doesn't matter where the patient comes through because we have different referral patterns. And because we have a very active cancer clinic, sometimes patients are directly referred to us. Regardless, before we make any decisions what therapy to use, we always bring the patient to this multidisciplinary clinic. And just for the audience to understand, this is about 15 physicians that are seated around the table, reviewing the case, reviewing the story, reviewing the history, reviewing physical exam, labs, images, and then we debate according to our local algorithm. Because unfortunately, differently than other diseases where there is a very clear-cut, step-by-step what we should do, neuroendocrine tumors, in my point of view, does not have a very clear cut and what we should do in every step of the way. So that's why the multidisciplinary discussion is important, because this is kind of we have some checks and balances, right? So there's nobody only doing one type of therapy, which we really try to provide what's the best for that patient, and then come up with a consensus. Regarding the desire to contact the other physicians, if the patient, after getting everything explained in detail in a follow-up visit, typically they don't have the desire to talk to everybody, because I think there's a trust that we represented them well, we discussed, and we're going to follow through what the tumor board recommended. And the tumor board recommendation is documented in the patient's chart, is documented in our case in the electronic medical records in Epic. The patients can see from home, they can see what the decision was, it's documented that, so it's live, they can see what the discussion was. So very transparent. But if the patient still wants to talk to every one of them, I always encourage to talk to our physicians and facilitate the referral. Or even some patients say, you know what, I would like to have a second opinion from, let's say, MD Anderson. And I always say, or MSK in New York, and I'd say, be my guest. Absolutely. I'd like you to go there and have a second opinion. And more likely than not, they'll come back to us and say, you know what, they said the same thing. So I think there is some, I think we've been providing world-class services to our patients at MUSC.
Thank you very much. That was really nicely summarized. Dr. Palmier, I'm going to summarize. This is a patient-specific question, but as we cannot directly give medical advice, I'm going to generalize this. One of the midgut nets issues is mesenteric or peritoneal carcinomatosis. Very tedious disease, difficult disease to treat. Most of the medicines don't really work well in this kind of scenario. If somebody post colectomy, now relapse disease, peritoneal carcinomatosis, and having recurrent partial small bowel obstructions, what would you recommend for the best treatment? A lot of abdominal pain. Can surgery be considered in these cases? How safe is it to operate? And how many times can you operate if patients have multiple surgeries in the past? That's a loaded question. Sorry about that.
Yeah, but it's a great question. My first question for carcinomatosis is, can we operate? And so I'd refer you to try to find the paper that we just published on this. And with the problem is, again, too many comparisons, I think, are made to other diseases. It's like if someone opens the abdomen of a patient with gastric cancer of the stomach, adenocarcinoma of the pancreas, colon cancer, pretty much everything other than ovarian cancer, and sees carcinomatosis, they just close things back up, thinking nothing can be done. And so we've been debulking them for years, and we just put that out in publication. So as I mentioned, when you open people up, 88% of people are a 3 or a 4 on that scale of disease. But if you work in the abdomen, and what can be done is several things. The abdominal cavity has a lining called the peritoneum. It's kind of like saran wrap, and you can cut it at various places and actually peel it off the underlying structures. And these little sesame seed tumors come along with it. And the beauty of it is they grow a new lining in about 5 days that's pristine and doesn't have those tumors on it. It's a different matter dealing with the organs in the abdomen because we can't peel the lining off the outside of the bowel and things like that. But you can go around picking these little tumors up and getting them out. And if there's a lot of disease on a segment of bowel, we'll resect that part of bowel as long as we're not going to give the patient a long-term problem like short bowel syndrome and worse diarrhea. Some patients may need a colostomy to get out all the disease in the pelvis, and that may be a permanent colostomy. So you have to talk to the patient as to whether or not they're willing to accept that. But it isn't very often. I can usually break through the pelvic floor and get down to a part of the rectum that has never been exposed to the abdominal cavity and reconnect people down there. And so we get people from, a 3 or 4, which doesn't have very good long-term survival rates, down to a 0 or a 1, 75% of the time. And that correlates with much longer survival. And yes, I will reoperate when people start getting obstructive symptoms. We are looking, and then, I can tell when I think I'm not going to be able to operate the next time when I'm in there. And we're referring patients now after that operation to get PRRT for the peritoneal disease as soon as they can if it's a small bowel neuroendocrine tumor. Some patients ultimately get to the point where, they run out of bowel. And I have patients who've lived for years on home total parenteral nutrition. They don't rely on their bowel anymore because they've lost too much of it. And again, that's a very tough decision for individual patients to make if they want to have that kind of a life. It's like Dr. Ramirez mentioned about if you have a transplant, you're buying a completely different kind of a lifestyle for yourself if you do that. The mesenteric masses are frequently a source of a lot of the pain and problem. And they're up at the root of the mesentery where the artery and vein keeping all your intestines alive are coming out of the back. And surgeons are trained from the first days of internship that is tiger territory. You don't go in and operate there. And because you could injure those vessels and end up losing all of the bowel. But centers of expertise are very good at removing these masses. You came from one in Louisiana that did it. And one of the things I wanted to do in that paper was compare the survival of patients who had their mass completely removed to those in which I couldn't. Well, I got it out in 95% of the cases, so there was no comparison group. It just shows that surgeons who are trained in these techniques, these very specialized techniques, can get a high rate of success that other surgeons just wouldn't dare venture into.
Thank you so much. Very well put. This would be an open question to both of you. For an uncontrolled carcinoid syndrome patient, would you rather incorporate benfeziapen as a solution, especially in the later part of the month when the symptoms are kind of getting worse, or would you move the sandostatin or lanreotide to a more closer frequency? Dr. Pommier, why don't you go first? Oh, I think
I haven't had much good success with increasing the frequency of octreotide. I was one of the investigators in the original octreotide trial, and we randomized patients to get 10, 20, or 30 milligrams, and we showed different blood levels in patients. There were higher levels in patients who had 30 compared to 20 compared to 10. But we actually saw no statistically significant difference in the control of flushing or diarrhea between those 3 doses. And the data of increasing frequency have not been very encouraging. So I move on to other therapies. It's like, what else can we do to get the syndrome under control if it's not being controlled by maximal acceptable doses of somatostatin analogs? So we can try talotrostat, and it is a very frequent reason for me to refer patients for liver embolization if we are not control. And I'll let Dr. Gomez speak to that. But the rates of getting carcinoid syndrome under control with embolization, even if they aren't progressing, is quite good in my experience.
Yeah, no, I agree with Dr. Pommier. We don't try to do anything more with the clinical therapy if the patient is not doing well, especially under progression of the disease. We simply do embolization. And as Dr. Pommier recognized, depending on the paper that you're reading, our experience has been between 90 and 100% of patients under control with embolization therapy. So I wouldn't try to do anything different than that.
Perfect. Thank you so much. Now, there is a question by a patient, and I think if one of you can explain the biology of a stage 4 disease, I think that's where it's kind of alluding to. So a patient had surgery, big tumors were removed, but seems like the cancer comes back, what the patient's referring to as a Dandelion effect, sprinkled throughout the liver, and these are much smaller. So now the patient apparently is on Cape-10 and the tumor seems to be gone. It is somewhat confusing to the patient that why after removing big tumors that the multiple smaller tumors came back in liver. And so I think if one of you can explain what is stage 4 cancer and how does the micrometastatic disease can still be there after removing the tumor, probably relieves the confusion.
I can go first. I think that stage 4 is basically when there is disease, there is metastatic disease, right? So there's disease in addition to the primary organ and the nodes, lymph nodes. And especially if there's multiple mets, that's where, in theory, the patient has a more advanced disease in the liver and in multiple other organs, for example. For those patients, we tend to have a more systemic approach and then count on great doctors like Dr. Chauhan that could potentially prescribe systemic chemotherapy. Remember that Lutathera has pretty good response as well to control in combination and can be, I would use in combination with systemic chemotherapy, systemic therapy. And try to be minimally invasive because this patient already has stage 4, right? So this is advanced disease. So we don't want to be too aggressive in that regard. However, if the patient has stage 4 and the predominant disease is still in the liver and has a little bit, let's say, in the lymph nodes in the retroperitoneum, for example, Then we have, let's say, in the spine as well. For example, let's say the patient would be probably benefit from local regional therapy, systemic therapy, and other ablation techniques. Like, for example, we can do ablation of lesions in lymph nodes in the spine. I'm not saying that's the standard of care, but I think it requires more tailored approach. The message here is systemic chemotherapy for stage 4 advanced disease should be more systemic, whatever systemic options are available where you are. But if there is a stage 4 with predominant liver disease, I think it's worth it to be aggressive in the liver therapy treatment with minimally invasive techniques, especially Y90 in this case, because ultimately what kills the patient, or the patient can lose their life, is because of liver dysfunction. So that's important to be told. It's not the lymph nodes that are growing and other organs that are involved, but primarily is the liver dysfunction, liver cancer, liver metastatic disease that is going to take the patient's life. And we can't lose that perspective.
Perfect. Thank you so much for that answer. All right, Dr. Palmier, can you tell us a little bit about ovarian neuroendocrine tumor? Are they always primary, or could they be drop mets or metastatic disease in ovaries?
Great question. I think they're metastatic. I've been doing this a long time, and I've found maybe one primary ovarian tumor, and now, based on all my other experience, I'm highly suspicious of that. But we published a paper on this about 2 years ago, and what we found was that about 23% of women with small bowel neuroendocrine tumors will get ovarian metastases. It correlates extremely highly with the presence of the carcinomatosis. So even if women are postmenopausal, their fallopian tubes are still working. They're in there wafting cell fluid in the abdominal cavity, trying to get an egg to go in the uterus. And so if you've got carcinoid cells loose in there, they go in there and they share a blood supply with the ovary, and the ovaries just love these cells. They grow very, very strongly there. This is another source for hormones to get back to the heart. All the intestines, any hormones being produced in that part of the abdomen, they go through the liver, where the liver has a chance to inactivate those hormones before they get back to the heart. But the ovaries drain straight back to the heart. So getting ovarian metastases can increase your chances of having syndrome and carcinoid heart disease, both. So we did not find any difference in survival of patients in whom we removed their ovaries versus did not. But we found a lot fewer complications. These ovarian metastases will cause bowel obstructions, and they will cause ureteral obstruction, because the ureters pass right underneath the ovaries, and all that peritoneal fibrosis from this disease can block a ureter, and the patient may need a stent or a tube put in their back to drain their kidney. So we want to get those out. So I talk to women if they have small bowel tumors, and I say, if you have carcinomatosis at all, and if I don't see any disease in there, I recommend we take them out then, because you will likely come back later on with ovarian metastases. And I ask all women whether or not they're just willing to give them up so they never see that problem. And most women in this age group are willing to have their ovaries taken out as part of the operation. That said, I got sent a woman who had, she was discovered to have very large ovarian masses, and they were about the size of eggplants, and a gynecologic surgeon took them out, and they were metastatic neuroendocrine tumors. So they sent her to me, and I said, oh, you have a small bowel neuroendocrine tumor, and I'll go in and find it. And it turned out she didn't. She had a lung tumor, and she also had metastases to the pancreas. So I have one case of a lung tumor that's metastasized to the ovaries.
Wow, incredible. Thank you so much. Let's move on. The next question is, Dr. Palmier, can you tell us a little bit about the role of pancreatic enzyme replacement? When is it needed? How effective it is? And a follow-up question to Dr. Ramirez is, diarrhea is one of the common problems in NET patients. It could be as a post-op short gut related, or could be pancreatic enzyme insufficiency or carcinoid syndrome diarrhea. But somebody who is having profuse amount of diarrhea. In this particular case, patient reports 10 to 12 stools, but no histological diagnosis. How suspicious are you about having this patient been having a undiagnosed NET? So Dr. Palmier first regarding pancreatic enzyme, and then Dr. Guimaraes, what would you suggest to a really bad diarrhea patient who doesn't have a diagnosis of NETs, but he suspects it could be NETs?
Okay, so pancreatic enzyme insufficiency becomes fairly common in all neuroendocrine tumor patients, and it's chiefly because of the somatostatin analog therapy, which it turns off the bad hormones of serotonin and VIP and gastrin and glucagon, and we want that. But it also turns off some of the good hormones that cause your pancreas to make enzymes, and so it typically doesn't appear right away. The longer somebody's been on a somatostatin analog, the more likely we are to see it. What I always tell people, and this goes along to the subsequent question, is that when a patient with a neuroendocrine tumor is having diarrhea, it isn't necessarily the hormonal syndrome. I say, you don't have a patient with carcinoid diarrhea. You have a carcinoid patient with diarrhea, and it's different. So this takes a lot of time. You have to sit down with the patient and ask a multitude of questions about the diarrhea. For example, does it happen when they eat? Does it happen when they eat particular kinds of foods? Because fatty foods are the ones that really need the pancreatic enzymes to be broken down. And if you don't have them, they pass through to the colon, where there are bacteria that have the enzymes to break these things down. And when they do that, that causes this explosive diarrhea with a lot of foul smelling gas. So I usually ask the partner if they're socially acceptable or not. And I get an immediate betrayal. Oh no, you can't take that person anywhere because they're just passing foul gas everywhere. And that's a big clue. Does the stool float in the water because it's laden with fat and therefore more like a bar of soap than it is, stool? Do they see grease droplets in the stool? That's another strong clue. And then it will work with pancreatic enzyme supplementation. There's a catch-22 about pancreas enzyme supplementation, and that is that these things come in little gelatin capsules, and it's designed that those will be released in the small intestine rather than in your stomach. The problem is those are made of gelatin, which is made of protein, and guess what you need to break down protein gelatin? Pancreas enzymes, which you don't have. So a lot of patients are prescribed these capsules, told to swallow them whole, and they get no improvement. And it's because of that. So I always tell patients, look, when we start you out on this therapy, I want you to break the capsules open and pour these little granules of pancreas enzymes into a cup of applesauce or some yogurt and eat that first. And then you can have your triple bacon cheeseburger with blue cheese salad dressing on your salad and French fries and a chocolate milkshake with whipped cream on top. And the enzymes will be there for you. And if you keep doing that long enough, eventually you may have enough residual enzymes in your gut that you can start swallowing the capsules whole and you will be able to break them down. But if not, it's not rocket science. You just go back to breaking them open. Different patients need different amounts of pancreas enzymes. I have patients that don't get a response unless they eat 6 instead of 1 or 2 capsules per meal. You really can't overdose on pancreatic enzymes. The only side effect of taking too much is constipation. And it's like, yeah, you wish. So people don't need to really worry about that. But there are lots of other things. It could be bile salt diarrhea because I frequently take out the part of the small intestine that reabsorbs bile, and bile is a detergent and it irritates the colon. Nurses give patients soap suds enemas to make them have a bowel movement. So the bile that doesn't get reabsorbed can give them diarrhea. There's short bowel syndrome. And all these have very different characteristics, and you got to take a long, detailed history about the patient's bowel. Carcinoid diarrhea will typically happen in the middle of the night, whereas all the other diarrheas won't. If you can go to sleep, your guts will go to sleep. So whether the diarrhea occurs in night while patients are sleeping is a huge clue to its etiology.
That was fantastic. And Dr. Guimaraes, somebody who does not have a known diagnosis of NETs, and a lot of time we do see these patients in clinic, either they have flushing or bad diarrhea and they've been worked up by GI doctors. how suspicious are you that there is an undiagnosed NET condition? And what would be your advice for these patients?
Thank you for the question. I think if the patient has, from the clinical standpoint, as you said, flushing, diarrhea, not only diarrhea, right? Flushing, especially diarrhea at night, as Dr. Pomir mentioned, if they have, if more advanced disease, shortness of breath associated with valvular disease. So then that you have it's painted a stronger picture here, indicating that the patient could have neuroendocrine tumor metastasis. As you know, most of the patients with symptoms will have liver metastatic disease. So then a good MRI or CT would be enough to identify the diagnosis of if the patient has disease or not in the liver. Today, with the technology we have in MRI, with using the right appropriate sequences that most of the medical centers, academic medical centers use in the country, should be no problem to identify even small lesions. Having said that, if the clinical presentation is not as strong as you described, patients just having diarrhea per se, then the cause of diarrhea could be many. And I think there are other reasons that are more common than to be related to cancer. For example, if the patient abuses of alcohol, patients could have allergy to food. Patient could be related to diabetes, could be related to inflammatory bowel disease, right? So Crohn's disease, ulcerative colitis. I mean, could be related to medications that the patients are taking. So hyperthyroidism can give also diarrhea. So there's multiple reasons. So I think before jumping the ship and trying to think, oh my God, I have cancer, I would stop the ship right there and try to have a good consultation with a strong GI doctor that could investigate malabsorption or the reasons for diarrhea, and then think about cancer. I would not jump directly thinking, oh my God, I have cancer, and that's why I need to start investigating, doing a bunch of things.
Great advice. Thank you so much. Dr. Palmer, I think I know the answer to this question, but since we've been asked, let's go with it. So the patient thinks that the primary tumor was in breast and it was removed because the patient underwent a lumpectomy back in like 1990s or 96. Now patient has the liver mets. Do you think in this particular case, since the true primary is unknown, can we still operate and get the liver tumors be operated? What do you think?
Well, it's a well-known phenomenon that small bowel neuroendocrine tumors metastasize to the breast. I have a whole retinue of women with small bowel neuroendocrine tumors who have metastases to the breast, and it's well described in the literature even. So that said, there are breast cancers with neuroendocrine features. And so you'd have to have a very careful review of the pathology and with a lot of special stains and find out, was that tumor treated with a lumpectomy a primary breast cancer with neuroendocrine features, or was it just neuroendocrine cancer? And of course, breast cancer can metastasize to the liver, regardless of what its flavor is. So after getting a good pathology determination by an experienced neuroendocrine pathologist, yes, they are still a candidate for liver surgery. And I would be extremely interested to see, when you're in the abdomen attempting to do that operation, is there a small bowel primary that has been missed this entire time? That is really the explanation for the entire picture. There's a rule in medicine called Occam's razor. It's like the simplest explanation is the most likely. And so, when you're trying to invoke that you have someone who has neuroendocrine tumor of the breast and now a neuroendocrine tumor of the abdomen, that's like you're using two diseases to explain something where one disease could explain everything.
Thank you. And just a small follow-up question to that, because there's a related question by another patient. Do you always explore when you cut open a patient, or it is for selective scenarios only?
No, I always explore. And I always run all the bowels and check the pancreas and check the duodenum and check the stomach and check the ovaries in women and all that. So yeah, it's like, as I said, my first rule is trust no one. who's been there before me. And if I'm the first there, well then, no one should trust me. But
Well, great. Thank you so much. Dr. Ramirez, now I know you're a big proponent of Y90 radio embo, and you do a lot of it, you have a lot of experience, but I think you also see and do other modalities of embolization. What is your personal take on Y90 versus TACE versus bland? And I'm also curious to see what as Dr. Palmier's group is doing in Oregon in terms of, do they have a particular preference? So Dr. Ramirez, why don't you go first? Sure.
Thank you for the question. I think to us is very clear. It's very, there is some steps to be followed here. So one, if we are considering liver-directed therapy, endovascular directed therapy, meaning through the arteries, not percutaneous in putting a needle for burning, for ablation, I believe the sequence of things should be radioembolization first. And if the patient have a partial response to that, which is more and more, we are seeing better response because we're increasing the amount of radiation that we feel comfortable injecting in the liver. Then if the patient fails, then we go with, after 3 months, we need to wait 3 months to have full response of Y90. That's the time that takes biological effect of the radiation in the liver. Then after that, we will propose bland embolization to our patient. And typically it requires 2 or 3 sessions. So with the reason why we prefer to do Y90 first is because the Y90 is just a flow-directed delivery of the particles that are embedded with radiation. And because we don't block the blood supply, I can always come back and do the technique that blocks the blood supply. If I do the opposite first, if I use the blend embo first, and I block the blood supply and the patient has residual disease, I basically closed my access. And there's no way to deliver radiation anymore, at least from the endovascular standpoint. So that's why I prefer that sequence. And it's important to mention to the patients again that the relatively newer technique in the last 3-5 years, we've been doing segmentectomy. Segmentectomy, understand the principle of surgery, right? You go and resect a segment. That's where the term comes from. Instead of us resecting a segment of the liver that has a nodule, cutting open and then removing that piece of the liver, which is a very good thing that I'm sure Dr. Palmier has a lot of experience doing segmentectomies. What we can offer as an alternative is to perform the same concept, destroying, not removing, but destroying that piece of the liver where the cancer is with an extremely high radiation dose. So I think that would be my recommendation. And I would not use chemoembolization because there's no chemotherapy with approved, or at least that I'm aware of, that would be used in an endovascular approach.
Dr. Palmier, how's the local regional therapy tackled in Oregon?
So there's no question that radioembolization is much better tolerated by the patients than the bland or the chemoembolization. There are plenty of data that when it comes to how sick a patient gets, there's no difference between chemoembolization and bland embolization. That all the pain and discomfort and nausea and weight loss comes from the embolization. It also matters if you have a gallbladder, because the gallbladder gets embolized with those bland and chemoembolizations. And so it's another good reason that we want to take them out while we're in there in case you get embolized later on. You'll have an easier time of it. So when radioembolization came out, man, it was the bee's knees. It's like we could do that. And as Dr. Gomez is saying, this is chess. You got to think 3 moves ahead, and you don't want to burn bridges by embolizing somebody. And the radioembolization left the access open. That said, we are now seeing some of our long-term survivors of radioembolization having problems with biliary sclerosis, that the bile ducts are starting to get scarred shut and they're getting jaundiced. And I don't think that was ever seen with the other kinds of cancers that were done with radioembolization, because it just didn't live long enough for that to ever show up. I'm interested in what your opinion would be about radioembolization in the new era of PRRT, because we've had some patients that we've done radioembolization on, and then when they get PRRT, a substantial percentage of them get biliary sclerosis and ascites. And the Penn group from Pennsylvania has reported this as well. Patients that had gone over to Europe to get PRRT before we had it, and then they came back and got radioembolized at Penn. That they had the same. So it's a matter. You got to keep track of your total dose to the liver. You can do radioembolization and PRRT as long as you keep track of the doses. And I think that's why it's really important to have a very skilled interventional radiologist, because they can be much more selective and targeted, putting the radio beads where you want them and not just globally embolizing the whole liver, so that you would be susceptible to these problems later on. So we're keeping very, very close track of our radiation doses. And if we think that the radiation with PRT might be a problem, we have gone back to bland embolizations on some of the patients as a preference.
So nice to hear the different practice patterns. And yeah, clearly we don't have data to support or for or against each of the practices. I think, there is recent publication suggesting that at least short-term safety data is there to support Y90 followed by PRRT. But what Dr. Palmier is alluding, we are still awaiting to see the long-term safety data in the era of PRRT. At Markey, we are also, for the time being, moving more towards bland embolization till we have more long-term follow-up data from the combination, the sequence, because I personally also have had some patients with biliary cirrhosis and post Y90 sort of, but it is also a lot dependent on the users, because the way you give these local regional therapies is highly dependent on the user, how skilled the interventional radiologist is. So definitely go seek an expert like Dr. Guimaraes. I think our time is up. I really wanted to ask one final. Yes, Dr. Guimaraes.
I'm sorry, but I think I need to mention one thing, and it's very important what Dr. Premier mentioned before. I think in the last 15 years, we've been doing radioembolization in the last 15 years, at least, at MUSC. And since the beginning until now, the technique has evolved. So I think I agree with Dr. Premier about the concerns about the excessive amount of radiation. But if you use the most up-to-date techniques, which is more super selective injections, number one, and checking the dose of radiation, I would have no concerns to use radioembolization first. For that reason, that it does not block the blood supply that the bland embo blocks. And if you watch the patient's total dose to the liver, you should be safe at this point. I don't think there's any data to prove against what I'm saying at this point.
Perfect. Thank you so much. I think our time for question and answers over. I see the headmasters popped up here. Bob's here. Thank you so much, gentlemen. Dr. Palmier, Dr. Guimaraes, pleasure to always hear you guys, hear the experts talk about their areas of expertise. And we had over 250, close to 300 patients logged in today, in and out of the session from all over the world. And what a treat for everybody to hear in the experts for this rare cancer. Thank you so much. And we'll sign out till next time.
Yes. Thank you all. And before you guys leave, I just wanted to say I'm completely blown away with not only the questions that were posed by the audience, but the panel discussion. And audience, really, you have to thank these three, as well as many times the other speakers who come to talk at these things. I chuckle, because I think they're thinking I'm like the Grim Reaper. I show up and, it's time to go. But, they were up, they worked their normal schedule, which is probably, 60 or 65 hours a week, and then put up upwards of 65 hours a week, and then put together presentations, spent their time today And this is all recorded. It'll be available on our website. So thank you all once again.